Hi, let me show you how you can analyze the urine and interpret a urine dipstick. By the end of this video, you know how to recognize the most important urine findings, and you can test yourself with a short quiz. Let's start with the appearance of the urine. Normal urine is clear and yellow because of its normal pigments. If someone drinks a lot of water, the urine becomes much lighter in color. In this situation, the level of antidiuretic hormone, also called arginine vasopressin or AVP in serum, is low. If someone hasn't been drinking enough, less water is excreted. The urine becomes more concentrated and the color changes to a darker yellow or orange. Importantly, all of these colors are still considered normal, as long as the urine remains clear. In this situation, AVP levels are high, so free water should remain in the body. Urine can also appear red. Red urine should always be investigated because one of the most important causes is hematuria, meaning blood in the urine. The blood may originate anywhere along the urinary tract, for example from a kidney stone, or from the kidney itself due to glomerular disease. In young women, menstrual blood can also contaminate the urine sample. There are also other harmless causes, such as eating beetroot or taking medications like rifampicin, an antibiotic that can turn urine and even tears red without indicating disease. Next, brown urine has two major causes. The first is myoglobin, which is released during rhabdomyolysis, which is the breakdown of skeletal muscle tissue. The second cause is cholestasis, which means the bile can no longer flow properly from the liver into the intestine. The bile consists of bilirubin, and bilirubin then accumulates in the blood and is excreted in the urine, causing the urine to become dark brown. Another abnormal finding is foamy urine. The urine itself may look completely normal, but patients often notice excessive foam formation when they urinate. And this usually suggests proteinuria, meaning large amounts of protein in the urine, and is a classic finding in nephrotic syndrome, where damage to the glomerulus allows protein to leak into the urine. Finally, urine may appear milky or cloudy. This is called pyuria, meaning white blood cells are present in the urine. Pyuria is commonly seen in bacterial infections, such as urinary tract infection, called UTI, or in acute interstitial nephritis. Now let's talk about the urine dipstick analysis. Keep in mind that every manufacturer arranges the test fields differently. The order shown here is simply for educational purposes. Let's start with blood. A positive blood test on the dipstick does not necessarily mean that red blood cells are present. The dipstick actually detects the molecule heme. This means it becomes positive when intact red blood cells containing hemoglobin are present, but also when free hemoglobin is present after hemolysis. In addition, myoglobin also contains a heme group, and that's why patients with rhabdomyolysis can have a positive blood test on the dipstick, even though there are no red blood cells in the urine present. Next is protein. The dipstick mainly detects albumin, and only when the amount exceeds roughly 200 milligrams. Small amounts of albumin are therefore not detected. Albumin in the urine may result from glomerular diseases such as nephrotic syndrome or chronic kidney disease. But it can also occur during urinary tract infections because inflammation or bleeding allows albumin to enter the urine after the kidney. The next parameter is leukocytes, although the dipstick does not detect the cells themselves. Instead, it detects an enzyme found in granulocytes. A positive result therefore suggests the presence of granulocytes in the urine and may indicate a urinary tract infection, since these are the cells fighting against bacteria. Leukocytes may also be present in acute interstitial nephritis, but then in the absence of bacteria. Next is nitrite, Some bacteria convert nitrate into nitrite, making the dipstick positive for nitrate. A positive nitrate test therefore strongly suggests a bacterial urinary tract infection. But however, a negative result does not rule out infection, because not all bacteria produce nitrate. You can also measure the urine pH. An acidic urine, generally below 5.5, is commonly seen in patients eating high protein or meat-rich diet, because these diets generate more acids along the way. Metabolic acidosis can also acidify the urine. And on the other hand, in contrast, alkaline urine with a pH above 7 is more common with plant-based diets. But also here, metabolic alkalosis can also make the urine alkaline, because the kidney increases bicarbonate excretion in order to normalize the blood pH. The next parameter is specific gravity. This tells you how concentrated or dilute the urine is. The normal range is approximately 1.01 to 1.03. A higher specific gravity means the urine contains more dissolved particles and is therefore more concentrated. This is called hyperstenuria and commonly occurs with dehydration or severe fluid loss, for example due to diarrhea. Do you remember how highly concentrated urine looks like? It can appear darker yellow or orange, but is still transparent. On the other hand, a low specific gravity indicates dilute urine, and this may occur when AVP cannot exert its normal effect, as in diabetes insipidus, or during osmotic diuresis, where substances such as glucose or calcium draw water into the urine. Next is glucose. Glucose appears in the urine when blood glucose exceeds the renal threshold of approximately 180 mg per deciliter or 10 millimole per liter. At this point, the kidney can no longer reabsorb all filtered glucose in the tubule. Glucosuria is the process of glucose in the urine and is therefore common in diabetes mellitus. It is also intentionally induced by SGL2 inhibitors, which are drugs that block glucose reabsorption and are widely used to treat diabetes and heart failure. Next are ketones. Ketone bodies are produced when the body switches from glucose metabolism to fat metabolism. This occurs during prolonged fasting, but also during diabetic ketoacidosis, where insulin deficiency prevents glucose from entering cells. And finally, there are two markers of bilirubin metabolism we can see in the urine. The first is conjugated or direct bilirubin. Note, only conjugated bilirubin is water-soluble and can therefore be excreted in the urine. Unconjugated bilirubin cannot. Conjugated bilirubin is produced in the liver and normally secreted into bile. But if bile flow is obstructed, as in cholestasis, conjugated bilirubin backs up into the bloodstream and is increasingly excreted in the urine, explaining the dark brown urine we discussed earlier in this video. And the second marker is urobilinogen, also known as UBG. It is produced by intestinal bacteria from conjugated bilirubin and is partially reabsorbed into the bloodstream. UBG can become elevated in liver disease when the liver can no longer metabolize it efficiently. The underlying physiology is a little more complex, so we'll cover this in another video. So now it's time for you to quiz yourself.